Good afternoon. I want to thank Dr. Montaner and the conference organizers for inviting me to speak to you today about chronic hepatitis B and HIV. In this talk, I hope to give you a snapshot of what we've learned about co-infection and how antiretroviral therapy is expected to benefit these patients. And in the end, I will review upcoming challenges and uncertainties in this arena. So let's start off by reviewing the natural history of HBV infection. As you can see, the strongest determinant of whether an individual who is acutely infected will go on to chronic persistent infection is age. As you can see, with perinatal infection, over 90% of the cases will go on to chronic persistent infection in the absence of prophylaxis. And in contrast, in adults who become acutely infected, only a minority, very few, 1 to 5% will actually go on to chronic infection. HBV is a dynamic and fluid infection. A chronically infected individual can go through different phases in their lifetime. HBV itself is not thought to be a cytopathic virus. The damage that occurs in the liver is thought to be immune-mediated. At varying times, there will be what I would term immune activity, characterized by elevation of ALT and necroinflammation in the liver. And up to 30% of individuals will go through cycles of this immune activity or flares, many of which are clinically silent, and eventually have enough of these cycles that they go on to cirrhosis. So if you understand this natural history, it's easy to remember why there is varying prevalence of chronic hepatitis B globally. In the US, Canada, and Western Europe, these are regions of low Hep B endemicity, largely because most of these infections occur in adolescents and adults, and now less so given universal HBV immunization. And of course, sexual transmission tends to predominate over percutaneous. By contrast, Asia is an area of high endemicity, largely because perinatal transmission predominates. And Africa is an area of intermediate to high endemicity, and in contrast to Asia, vertical transmission is thought to play less of an important role, possibly because there is a lower prevalence of E antigen positive mothers. So what happens when you add HIV into the mix? Well, it's clear that co-infection is common due to shared routes of transmission. In fact, if you look at an HIV-infected population, serologic evidence of past HBV exposure can be present as high as 80% among HIV-infected patients. And chronic HBV prevalence ranges from 5 to 15%, depending on the population you look at. For example, in the US, the prevalence of chronic hepatitis B is estimated to be 20-fold higher in HIV-infected patients compared to the general population. And risk groups for HBV acquisition in these areas of lower Hep B endemicity are intravenous drug users, men who have sex with men, persons with multiple sex partners. But ultimately, the highest rates of HIV and hepatitis B co-infection are really found in sub-Saharan Africa, the Indian subcontinent, and Southeast Asia. And you can see this illustrated here with the darker green areas reflecting areas of high endemicity for HBV. Of the 350 million individuals globally who live with chronic infection, the vast majority of these live in resource-limited settings. And unfortunately, some of these regions also happen to be highly endemic for HIV. So what are the consequences of HIV and hepatitis B co-infection? Well, we have observed that HIV-infected persons who are susceptible and that get infected appear to have a higher risk of developing chronic hepatitis B when exposed, and therefore this is a priority group to immunize. And we have observed in the pre-HAART era that co-infected patients have a lower rate of E antigen seroconversion. So when in the hepatitis world, we think of E antigen seroconversion as an important immunologic milestone of Hep B control. E antigen seroconversion means the loss of E antigen and the emergence of E antibody, and this generally occurs in the setting of viral clearance and a lower ALT, and this can occur spontaneously. This happens less so in HIV-infected patients. There are generally higher levels of Hep B viremia, and with that, higher risk of Hep B reactivation and transmission. And there's evidence of higher rates of disease progression, cirrhosis, decompensated liver disease, and hepatocellular carcinoma, particularly in those who have low nadir CD4 counts. And there's been older literature to suggest that this population has a poor response to interferon-based therapy, which is not surprising considering interferon does rely on the host immune response for viral clearance. And ultimately, this group has an increased risk of liver injury on and off highly active antiretroviral therapy. And in fact, hepatitis B flares due to immune reconstitution, particularly in those with low nadir CD4 counts, can be misinterpreted as drug hepatotoxicity. I do want to point out, however, that co-infected patients can be more vulnerable to drug hepatotoxicity, although this occurs less frequently with antiretroviral therapy, at least the more updated versions, newer versions that we're using than, say, with anti-TB therapy. Furthermore, a multi-center prospective study, this was a study of the MAX cohort, which some of you may be familiar with, over 5,200 men who have sex with men, were followed prospectively, and this study showed that persons with hepatitis B and HIV co-infection were 8 times more likely to die of liver disease than patients infected with HIV alone, and 19 times more likely than those with hepatitis B alone. And these findings have been reproduced in other cohorts. The mechanism for this greater disease burden has not been fully elucidated, but it is worth mentioning that co-infected patients, as I mentioned, tend on average to have greater viral burdens. And this is relevant because of 2 major natural history studies that had long-term follow-up of hepatitis B mono-infected patients and highlighted the role of Hep B viral replication in disease progression. And you can see here that the baseline Hep B viral burden had a dose-dependent relationship with the likelihood of later developing hepatocellular carcinoma and cirrhosis. And this was independent of E antigen status and ALT. These findings have been the rationale, they're the bulwark for which we're treating hepatitis B more aggressively and why we're aiming for a goal of complete Hep B suppression in our effort to reverse this natural history. So let's examine natural history again. As I mentioned earlier, it's the individuals who are in the immune active or immune clearance stages, as shown here, with fluctuating viral levels, fluctuating LT, that are, and this can be folks who are E antigen positive or E antigen negative, who can progress to liver disease severity. And at times, these folks can gain control of their hepatitis B and evolve spontaneously into a quiescent or inactive carrier state characterized by normal ALT and low viral levels. The antigen positive patients are thought to be more likely to do so than their E antigen negative counterparts. And essentially, our goal with Hep B therapy is in essence an attempt to induce inactive carrier state, where there's no inflammation and the risk of progression to cirrhosis is much lower. So as shown here, our short-term goals are to suppress viral level, normalize serum ALT, induce the loss of E antigen if they're positive at baseline, and ultimately our holy grail is to induce the loss of surface antigen, although that is a much rarer event. And in the process, reducing necroinflammation and fibrogenesis. And then in achieving these short-term goals, we hope in the long term to delay development of end-stage liver disease, to reduce the risk of hepatocellular carcinoma, and ultimately to improve survival. But when you think about the goals of highly active antiretroviral therapy in co-infected patients, in addition to inhibiting viral replication, we hope to prevent Hep B transmission and acute Hep B among using Hep B active nucleoside analog therapy. And I'll pause here to mention that there has been a study from Germany presented at last year's CROI and published in this month's AIDS that did show that tenofovir-based antiretroviral therapy can work essentially like hepatitis B PrEP, or pre-exposure prophylaxis, and reduce a susceptible person's likelihood of acquiring hepatitis B. And in addition, we hope to restore adaptive hepatitis B-specific immune responses and innate immunity, and with that, reduce the aberrant immune activation that may play a role in hepatic fibrogenesis. So what do we treat hepatitis B with? Well, aside from interferon, there are 6 oral antiviral agents, all of which, in contrast to interferon, have the advantage of low toxicity. I have bolded the ones that have activity against HIV, and among these choices, the one with the highest potency and greatest barrier for resistance is tenofovir, and it means the first choice agent for both mono and co-infected patients. But at this time, we have clinical outcomes data primarily on lamivudine, largely because it is the agent that has been around the longest. In this study, Hep B mono-infected patients with advanced liver disease, lamivudine was shown to result in slower disease progression and lower incidence of HCC. And this study is essentially our primary proof of concept for the benefit of antiviral therapy in hepatitis B. However, we are starting to see more of the long-term benefits of tenofovir treatment, and in this study published in The Lancet last year, 87% of nearly 350 Hep B monoinfected patients who were treated with tenofovir showed histologic improvement on liver biopsy, and 51% had regression of their fibrosis by year 5 of treatment. We don't as yet have comparable large-scale clinical outcome data in co-infected patients, but we do have some smaller studies that demonstrate efficacy of tenofovir in both viral suppression and e-antigen seroconversion, as well as a handful of case reports that have shown improvement in clinical and laboratory parameters in patients with advanced disease who have achieved sustained viral suppression on tenofovir-based HARDs. So extrapolating from the literature on mono-infected patients, I think, is reasonable, but I would argue that this needs confirmation in co-infected patients. In addition to the care of co-infected patients, our focus should be on primary prevention in those who are susceptible to hepatitis B. Hep B immunization has had great success, particularly as part of a national program in reducing surface antigen seroprevalence. But unfortunately, its efficacy, while high in immunocompetent patients, is limited in HIV-infected patients, with responses ranging from 25 to 45%, depending on the case series. In our HIV clinic in Seattle, we examined factors associated with reduced vaccine response and found that nadir CD4 count and ongoing HIV viremia were two key independent predictors of lack of response. Before I wrap up, I did want to highlight some of the unique challenges encountered with managing co-infection in resource-limited settings where both infections are common. It's worth noting that hepatitis B immunization programs are not universal in a lot of these settings. Hep B screening is not routinely performed. And moreover, first-line antiretroviral therapy of HIV-infected patient often includes lamivudine in the absence of tenofovir. And so in essence, patients who are hepatitis B infected are getting lamivudine monotherapy. And why that is relevant is that there have been a number of studies that show that up to 90% of co-infected patients treated with lamivudine monotherapy develop Hep B resistance to lamivudine for years. And this is the very low genetic barrier for resistance, and this is not a durable agent, and therefore not the first line. And because of this, in 2011, the WHO recommended that tenofovir be part of the first-line antiretroviral therapy in co-infected patients. But the WHO has not yet provided some specific guidance on Hep B screening. And so in essence, Hep B treatment in many resource-limited settings is blind to Hep B status with potentially grave long-term consequences, including viral breakthrough on lamivudine and clinical flares. One of these consequences may also be delayed Hep B suppression and ongoing viremia on tenofovir, which would be the next future step in Hep B treatment. In a multi-center observational study of patients in clinical care in the US, most of whom were e-antigen positive, we found that lamivudine-exposed patients were less likely to suppress their Hep B promptly on tenofovir, and their median time to Hep B suppression was 50 months compared to 17 months in those who were lamivudine naive. A lower nadir CD4 count was also associated with delayed Hep B suppression, and both findings underscore the influence of treatment experience and immune status on Hep B clearance. So I will end here by noting some of our knowledge gaps and areas where we can dig deeper with research and collaboration. We need to start by making a concerted effort to assess regional prevalence of co-infection, especially in resource-limited settings where both infections are endemic. We need to have a better understanding of the mechanisms for accelerated Hep B disease progression in co-infected patients, as well as try to assess the comparative risk of hepatocellular carcinoma. I didn't show data on HCC, but it is clear that it is emerging as a major non-AIDS related malignancy. We have to examine the impact of Hep B active nucleoside analog therapy in reducing liver-related morbidity and mortality in co-infected patients in the post-HART era. And an area of particular programmatic interest, especially in settings where childhood immunization programs are not widely available, is the role of these therapies in reducing perinatal transmission. The impact of ART for this outcome remains largely unknown. And finally, we need to come up with better strategies to improve Hep B vaccine efficacy in this population. I'll end here. Thanks for your attention.